Hello, this is Dr. Michael Conti, and today we will be talking about the osteopathic approach to the genitourinary patient. The objectives of today's presentation is to discuss the role of osteopathic manipulative treatment in a patient with genitourinary complaints, to identify viscerosomatic reflexes common to the GU patient and be able to use that information to enhance our differential diagnosis and treatment, to demonstrate understanding of the primary areas of potential somatic dysfunction in the GU patient and how we can address them, to identify potential somatic dysfunction causes for pelvic pain and GU dysfunction, including such conditions as UTI, prostatitis, ureterolithiasis, dysmenorrhea, erectile dysfunction, premature ejaculation, dyspareunia, and infertility, to describe Chapman's reflexes and their role in a GU patient, and to discuss and review osteopathic research in the GU patient. I always want to start review with the osteopathic tenets. Again, not only is this important to our practice of osteopathy, but we'll also see this on your board exams. So you remember at first, we are a dynamic unit of function. The body has self-regulatory mechanisms. Structure and function are interrelated, and rational treatment is based on these principles. So the urinary system is comprised of the elements of the kidney, ureters, bladder, and urethra. Kidney has a glomerulus and collecting system, and the urine then flows into the ureters that collect the urine and transmit them to the bladder, which stores the urine, and then the urine exits through the urethra out of the body. And the kidneys regulate the excretion of water and solutes and also are involved in the control of blood pressure and production of red blood cells. But more importantly, focusing on the anatomy, which will be helpful in the osteopathic treatment considerations. Thinking about the kidneys, the left kidney is usually a little bit larger than the right, about 10 to 11 centimeters. And they're retroperitoneal organs, and the kidney usually sits higher on the left side at about the T12 to L3 level. And the right is just a little bit lower, but in that same ballpark. They're supported by fascial connections with collagen bundles through the fat in that retroperitoneal space, and they have their own fascia and pararenal fat that surrounds them. And the main attachment point is the diaphragmatic fascia. Surrounding elements superiorly would be the diaphragm and the pleura of the lungs, anteriorly the peritoneum, posterior aspect the quadratus lumborum and psoas. But the fascia is not continuous, and it actually allows movement of the kidneys inferior, and that follows with the diaphragm during inhalation and exhalation. And so with each breath, the kidney moves inferiorly along the psoas, with the superior portion moving just a little anterior with a little tilt, and some external rotation also occurs. And this motion is about the distance of one vertebral segment, about 3 to 4 centimeters. And the kidney actually travels quite far during the day, this 3 to 4 centimeters multiple times a day, up to about 600 meters on average. And since the kidney does transverse over the psoas, a psoas spasm can generate fascial restriction and inhibit, in some cases, kidney motion. The ureters are thick-walled muscular ducts with a narrow lumina that again transmits the urine down to the bladder. It's also a retroperitoneal structure, and surrounded by a sheath, actually is the psoas fascia, and it also courses inferiorly over this fascia, and the ureters cross the brim of the pelvis and the external iliac artery. So there are 3 points of possible constriction at the junction of the renal pelvis, at the pelvic brim, and as it passes to the urinary bladder. And again, psoas contracture or spasm in this area may affect the fascia, which can then adversely affect the ureteral function. The bladder rests on the muscular floor of the pelvis, the other associated muscles, the detrusor and the trigone of the bladder, and it attaches at the pubovesicular or puboprostatic ligaments. Otherwise, bladder hangs fairly freely in the abdomen, and again is suspended by thickening of the peritoneal wall. And again, you have the pubic bones and the vesicular fascia surrounding the bladder, and then again, which empties into the urethra, and the urethra pierces the pelvic diaphragm at the voluntary urethral sphincter. And again, the motion of the kidneys as with respiration, inspiration, expiration, is a downward external rotation, and this pendulum-like motion around a frontal axis. The ureters also follow the kidneys in that movement, and the upper pole, anyway, of the ureters follow the kidneys, and the lower aspect of the ureters more relate to movement with the bladder. Bladder motion moves more with the sacrum and the uterus, rather than with the abdominal diaphragm as the kidneys do, and the bladder moves posteriorly and superiorly with inhalation. In regards to innervation, the kidneys and upper ureters receive their sympathetic innervation from the superior mesenteric ganglion at the levels of T10 to L1, and parasympathetic fibers originate from the vagus, again cranial nerve 10. For the bladder and the lower ureters, sympathetic innervation comes from the inferior mesenteric ganglion at the T12 to L2 levels, while parasympathetics originate from the pelvic splanchnics at S2 through 4. With an increase in sympathetic tone, there's an increase in afferent arterial constriction to the kidney, also ureterospasm and decreased peristalsis of the ureters, also a relaxation of the bladder wall that can lead to reflux, and an increased tone to the external urinary sphincter. So these changes, due to the sympathetic activation, cause a decrease in the GFR and a decrease in urinary output. This also will increase blood pressure, and the ureterospasm mentioned above will decrease urine flow through the ureters, causing urine to back up in the system. Encourages incomplete emptying of the bladder, and ureteral and prostatic reflux from the bladder, and also can cause premature or retrograde ejaculation. On the parasympathetic side, increased tone will increase the peristalsis of the ureters, will also increase the bladder wall tone and relax the internal urinary sphincter. In contrast, decreased parasympathetic tone can result in incomplete emptying of the bladder, impotence, and tightening of the internal urinary sphincter. The lymphatics of the urinaries really are a safety valve that aids in waste clearance. It drains the capsule and the parenchyma and prevents backup of fluids. The flow of the lymphatics start in the capsule and the parenchyma, move to the preaortic nodes, then drain into the thoracic duct and the subclavian vein. And really, synchronous thoracic and pelvic diaphragm motion is quite vital to lymphatic drainage. With an impaired lymphatic flow, this results in increased oncotic interstitial pressure and disrupts the countercurrent exchange, resulting in the inability to properly concentrate urine. You also risk increase of kidney damage because of obstruction from the ureters. In regards to viscerosensory and visceromotor reflexes, in the renal system, a viscerosensory pain is described as more of an ache, and usually refers pain to the thoracolumbar region, flank, or both. In regards to visceromotor, there's an increased thoracolumbar junction tone, which gives you the positive Lloyd's or punch test that you see in people with kidney issues, especially renal calculus. For ureteral viscerosensory reflexes, you see more of ureteral colic, which is this pain that moves from the lumbar region and the iliac fossa, coming over the anterior abdomen into the scrotum, and even into the labia. And in the visceromotor aspect from the ureters, tension in the abdominal and erector spinae and cremasteric muscles occurs, and you kind of see this for a stone that passes through the ureters. This reflex progresses starting about the T10 level up near in the kidney itself, and as it progresses down the ureters, you start getting more pain moving down the lumbar spine. Somatic referrals from the urinary system, starting with the pudendal nerve, which innervates the external urethral sphincter tone, and this runs from S2 to 4. Sudden increases in intra-abdominal pressure cause the pelvic diaphragm and external sphincters to contract in this protective reflex arc, but if there's inadequate contraction, this leads to the condition of stress incontinence. People sometimes get when coughing, sneezing, and having loss of urine. Increased tone or a spastic pelvic diaphragm that is not synchronous with the thoracic diaphragm can increase intra-abdominal and intrapelvic pressure, and this can aggravate symptoms in folks with esophageal and inguinal hernias. In regards to short leg and psoas syndrome, this is a frequent cause of back pain, but when combined with functional urinary changes, that back pain as well can be mistaken for UTI or ureteral colic. Postural disorders can lead to pelvic tension myalgias, and these symptoms are frequently misdiagnosed as prostatitis. For an iliolumbar ligament strain, which commonly results from postural disorders, this can refer pain to the groin and be mistaken for an inguinal hernia. Somatic dysfunction of the pubic symphysis with tension in the urogenital diaphragm or the puboprostatic or pubovesicular ligaments may cause urinary changes and symptoms such as dysuria, urgency, and frequency. And this is commonly seen in postpartum or post-cystoscopy or perineal surgery patients, and happens when they're taken incorrectly out of the stirrups after the procedure. causing this strain or tension in those areas. And in pediatrics, this condition is associated with nocturnal enuresis. Lower abdominal trigger points may also cause urinary frequency, urgency, sphincter spasm, some residual urine, or bladder pain mimicking urinary conditions. Onto the genital and reproductive system. Of course, the organs of note are the ovaries, uterus, fallopian tubes, cervix, vagina, and clitoris in females, and prostate, testes, vas deferens, seminal vesicles, and penis in the males. Also the Cowper and Bartholin glands. And the innervation to these areas, T10 through T11, commonly the testes and the ovaries, and T11 through T12, the fallopian tubes, uterus, vagina, vas deferens, and seminal vesicles. T12 to L2 innervates the prostate, Cowper and Bartholin's glands, and the penis, which is more L1 to L2. S2 through S4 innervate the cervix, vagina, clitoris, penis, and urethral walls. So in the genital and reproductive system, increased sympathetic tone will activate the fallopian tubes, uterus, vagina, vas deferens, and seminal vesicles. This will also trigger prostate glandular secretion, and the pudendal nerve will cause muscular contractions and force secretions out of the urethra. Increased tone will also activate smooth muscle in the penis, leading to orgasm and ejaculation. And a significantly increased sympathetic tone will cause premature ejaculation, usually facilitation of the L1 and L2 segments. This will also cause gonadal hormonal secretions from the testes and ovaries. Decreased sympathetic tone could lead to dysfunctional ejaculation disorders, and this is especially seen in diabetic patients. Parasympathetic stimulation for the genital reproductive system will activate the cervix and will mildly inhibit the body of the uterus and relax the corpora cavernosa in the penis, causing erection. Decreased parasympathetic tone will lead to impotence, impairment of the erectile capabilities of the penis. Lymphatics in this system require synchronous thoracic, which is an active motion, and pelvic passive diaphragm motion, working together to affect proper lymphatic drainage. And the prostate specifically fills this defect in the pelvic diaphragm and actually kind of plugs up that defect and is continually massaged by the passive pelvic floor motion when there's no restriction in that diaphragm. Congestion of the lymphatics can lead to dysmenorrhea, ovarian cyst, PMS, and increased vaginal secretions. PMS specifically looking at edema, back pain, headache, depression, weight gain. So it's very important to get those lymphatics flowing. In regards to gonadoviscerosensory sensations, this causes groin pain that radiates down the thigh. In addition, the iliolumbar ligament can refer pain that mimics this kind of pain from GU disorders. So something to keep in mind. Visceromotor sensations cause lower abdominal muscle and T10 through 11 paraspinal muscle rigidity. Viscerosensory pain referral patterns, commonly for the fallopian tubes, is down the flank, iliac fossa, and down the anterior thigh to the knee. From the uterus, pain refers down the thoracolumbar junction to the abdomen and occasionally the sacral region. From the ovaries, T10 is the most common pain referral site. Fallopian tubes is T11 through 12. Uterus T10 through L1 and cervix S2 through S4. The prostate usually refers pain down the thoracolumbar and sacral regions, but it can also refer pain in the glans penis and cause urinary frequency and rectal discomfort due to a common pelvic nerve connection. And the penis by itself is more subject to reflex sensory disturbances coming from other organs such as the renal, ureters, bladder, urethral, testicular, prostatic tissues than from actually sending pain itself. And inflammation or infection will actually facilitate the lumbar 1 to 2 segments and has been reported to cause almost continuous sexual desire, and this actually is the reason historically how many aphrodisiacs come to be known, as they induce this bladder irritation and set up the segmental facilitation, which is thought to heighten sexual desire. Somatic considerations, a big one is the psoas muscle, implicated in gynecologic dysfunction due to its proximity to these associated GU vascular, neurologic, and lymphatic elements. Chronic psoaspasm has been reported in a case to cause anovulation, and chronic ovarian inflammation can lead to reflex psoaspasm. Pulsar disorders such as short leg syndrome can cause pelvic pain and Lower rectus abdominis trigger points can exacerbate dysmenorrhea symptoms. SI joint seminal dysfunction or spasm can also refer pain suggestive of disorders of the cervix. In regards to disease-specific osteopathic considerations, in a patient with a urinary tract infection, you'll get a positive Lloyd sign with this kidney infection or posterior peritoneal irritation. In treatment, you want to rule out pubic symphysis and pelvic floor dysfunction, treating symptoms of such as urinary pain or frequency. Incomplete emptying, reflux, or loss of normal ureteral peristalsis will increase the risk for an ascending infection, and you want to make sure you treat the thoracolumbar junction and SI joint, so specifically T10 through L2 and S1 through 3. In cases of prostatitis, specifically acute or chronic bacterial prostatitis, you really want to avoid digital massage of the prostate in acute infection, as this could increase the risk of bacteremia. But for these patients, you want to treat the ischial fossa, T12 through L2, and S2 through 4 specifically. In more chronic prostatitis of a non-bacterial etiology, treat somatic dysfunction, again in your lower thoracics and upper lumbars in your S2 through 4 regions, along with the pelvic floor. In treating prostatodynia, which is characterized by variable pelvic pain, intermittent urgency, frequency, nocturia, dysuria, hesitancy, and weakening of the urinary stream, symptoms are related to increased sympathetic tone and increased tension in the pelvic diaphragm, which will cause spasm during voiding. So you want to make sure you treat the pelvic floor and associated sympathetic regions. In patients with ureterolithiasis, or ureteral calculus, pain coming from the calyces, renal, pelvis, and ureter refer to the back. Bladder stones would refer more suprapubic pain. Ureterospasm that can occur with the calculus will increase pain and slow passage of the calculus through the system. So you want to treat this increased sympathetic tone in the ureterospasm with thoracolumbar, paraspinal inhibition, or you can use gentle rib raising. You want to avoid morphine in these patients, as this will increase the ureteral spasm and make it harder to pass the stone. Specifically, you can address anterior counterstrain treatment for the iliopsoas and treat the GU Chapman's reflex points. You also want to treat any SI joint somatic dysfunctions, as this will assist physiologic ureteral peristalsis. And of course, you don't want to forget the lymphatics. With dysmenorrhea, patients present with painful menstruation and cramp-like pain, usually found in the lower abdomen, sometimes in the back and thighs, and the symptoms are aggravated usually by stress. There's an autonomic postural row that's implicated in this condition, where one study found an increased incidence in college-age women with increased lumbar lordosis. Occasionally, this can be associated with an acutely anteverted cervix, which has the uterine fundus tipped anteriorly. For treating these patients, you want to focus on the lower rectus abdominis myofascial trigger points. You also want to normalize sympathetics at T12 through L2, which work on uterine contraction and vasoconstriction when overstimulated. We also want to normalize the parasympathetics from S2 through S4, which work more towards uterine inhibition and vasodilation. As always, you want to increase lymphatic and vascular drainage of the pelvic organs. Specifically, you can use a firm, continuous anterior pressure over the sacral base in a patient in the prone position, which works on the parasympathetic and lymphatic system. And this is a sacral equivalent of the cranial CV4 treatment, which was primarily used to relieve tissue congestion. So this can be very helpful in patients with a lot of tissue congestion in the pelvis. And also sacral rocking in the prone position, using the sacrum's natural rhythm of 10 to 14 times a minute. And this can improve parasympathetics to those pelvic organs involved. For patients with erectile dysfunction, erection occurs with activation of the pudendal nerve S2 through 4, somatic input, and parasympathetic reflexes from S2 through 4. And you want to treat associated sacroiliac somatic dysfunction in these patients to normalize function. For premature ejaculation, again, ejaculation is a sympathetically mediated response through L1 through 2 with somatic S2 through 4 contribution. And you want to treat somatic dysfunction in that lumbar region L1 through 2, which will reduce facilitation and normalize nerve input to that region. In dyspareunia, which is painful intercourse, most causes are vaginal spasm, inadequate vaginal lubrication, pelvic floor spasm, or lesions or other genital tract abnormalities. You want to treat specifically the pelvic diaphragm and its attachments, and normalize the parasympathetics, which will increase vaginal lubrication. For patients with infertility concerns, you need to follow a multifactorial approach, which may include dysfunction in physiology of either or both partners. You want to treat the thoracolumbar region and the pelvic region somatic dysfunctions that you may find. You also want to reduce postural disorders that might be perpetuating segmental facilitation. You also want to examine the cranial and sacral areas and look for somatic dysfunction, which could be affecting normal pituitary or ovarian axis hormonal secretions. And benefits have been found with OMT that help promote regular periods, have been found to increase spermatic counts, and that's found in a study just using systemic OMT, not necessarily OMT specific to the pelvic region, and also reduce stress, again by affecting segmental facilitation and reducing that in these patients. And again, as we've covered before, we'll cover again Chapman's reflexes, and now specifically for the genital urinary tract. So what are Chapman's reflexes? Well, they're hypercongestion from hypersympathetic tone to deep intercostal fascia resulting in lymphatic edema and myofascial thickening. This is reflected as a painful nodule that is described as small, smooth, firm, discretely palpable, and approximately 2 to 3 millimeters in diameter. And this is utilized in osteopathic manipulative treatment not only as a treatment but also diagnostically to help confirm diagnosis and the regions affected. And research into the efficacy of Chapman's reflexes is somewhat limited, but a study by Menino D.O. studied hypertensive patients and reported in the JAOA back in the December 1979 issue that a 15 millimeter of mercury decrease in systolic and 8 millimeter mercury decrease in diastolic blood pressure, as well as decreased serum aldosterone levels, was found 36 hours following a Chapman's reflex treatment. Treatment of Chapman's reflexes involves firm pressure by the finger pad of the physician on the point in a small circular pattern in order to mobilize a localized fluid accumulation. Small circular motion should be applied for about 10 to 30 seconds or until this mass disappears. Now specifically for the GU patient, these are our anterior Chapman's points, and these are their posterior points. They're not as well circumscribed as the anterior points, and feel more like a somatic dysfunction than like a specific BB or small nodule feeling like as they do in the front. Research related to osteopathic and manual medicine in the GU patient, specifically for UTI, this systematic review published in the Journal of Bodywork and Movement Therapies in 2013 showed that OMT presents a statistically significant and clinically relevant improvement compared to an untreated group. And two studies that actually compared OMT with pelvic floor muscle training as a reference document almost the same therapeutic effect. For prostatitis, this 2009 randomized controlled study out of Germany showed that OMT came up with statistically significant improvement in symptoms of prostatitis versus a placebo group at a 6-week follow-up, and persisted also to a 1.5-year follow-up. And a long-term follow-up of this study, published in 2013, shows sustained improvement in symptomatology versus that placebo group at a 5-year follow-up. For dyspareunia and pelvoperineal pains, this 2008 clinical study out of Paris showed 6 clinical cases and 1 global study on 86 patients that demonstrated after 2 manual medicine sessions there were satisfactory results in 71% of patients on their symptom treatment. And for dysmenorrhea, a 1993 study showed that OMT significantly decreased EMG activity during L-spine erector spinae activation, which actually coincided with patient reports of alleviation in back pain and menstrual cramping symptoms. And a Cochrane review in 2006, utilizing 4 HVLA studies of various modalities, show that intervention is no more effective than sham treatment. However, the intervention may be more effective than no treatment. And there was no greater risk of adverse events with spinal versus sham manipulation. In regards to infertility, a case series in the Journal of the American Osteopathic Association in 2012 showed that multiple modalities, using various techniques such as muscle energy, lymphatic drainage, and visceral manipulation, demonstrated that 10 infertile women received 1 to 6 sessions of manual therapy in the pelvic region, Actually, 6 of these 10 women conceived within 3 months of that last treatment session, and all 6 of those women delivered at full term. So this demonstrates manual manipulation may in fact be able to help with infertility by helping treat somatic dysfunction. These are the references I utilized for my presentation: Kuchera's Osteopathic Considerations in Systemic Dysfunction, Foundations of Osteopathic Medicine, and thank you to these other physicians for their assistance in this presentation. Thank you all for watching, and we'll see you in the lab.